morning, everyone. I'd like to thank Sonal for having me here, and I'm even more thankful for putting me as a youngster. Right?
Yeah, so here we have a role reversal, okay?
And my PG didn't thought it was me because it said youngster, so it was somebody else. Right? So anyway, you're not same batch, so I thought you put me as a youngster. Yeah, we are youngsters always. Right? I'm always fascinated by anatomy. They didn't believe me until Grey's Anatomy came up. That is what we are going to deal with. This is the structure we are in. So that is Catherine Zeta-Jones and Tom Cruise, right? We have to don the role. Imagine Sonal and myself, that is to navigate through the mandible, right? My topic is extraoral anatomy, and I'm a bit upset about Sonal because she restricted me a lot. She wants to be only with symphysis and ramus. She didn't want to interfere in the condyle as well. So my role is very, very limited here. So I'll deal with anatomy related to this symphysis, ramus and angle region. And all we have to think about is only 4 structures. That is what I'm going to talk about. One is marginal mandibular nerve, facial artery, facial vein, and retromandibular vein. That is the only thing which is going to be repeated again and again. So we'll see anatomy related to submandibular approach. The first and foremost thing which comes is marginal mandibular nerve, which of course everyone knows it lies almost 1 centimeter below the lower border of the mandible. That is, most of the studies there are variations. There are variations about number of branches as well. Most of the time it's almost 1 centimeter below the lower border of the mandible. So stay safe, away from 1 centimeter you are safe. And this is a surgical anatomy. As you know, the facial nerve divides into 2 main branches, temporofacial and the cervicofacial. The marginal mandibular comes below cervicofacial. It origins within the substance of the parotid gland. So that is the nerve which comes here, which is really entangled with the other structure as well. That is what is the facial artery. This is another structure which comes through when you are going to approach through a submandibular or residence incision. Mostly it crosses the lower border of the mandible anterior to the masseter. This is one more surgical anatomy which is very important. You have to palpate the anterior border of the masseter. That is the key area where all these structures will confluence, and that is where we are going to deal with them. And imagine that artery is always anterior to the vein. Vein will be posterior. Right. This is the facial artery. It origins from the external carotid artery deep down the digastric muscle, and then it crosses over the digastric and the styloid, and then on the posterior region, right? That is the posterior region. Thank you. Oh, sorry. How to use the pointer? Okay, I'll just use the cursor. See, just over the digastric muscle, it grooves over the submandibular gland. It has a hook. It goes medial to the mandible and then comes out to the submandibular gland, grooves the submandibular gland, again emerges at the angle of the mandible. That is the facial artery. In case if you are dealing with excision of a submandibular gland, you have to ligate at a couple of points. One at the medial level and one at the lateral level. That is the important feature here. Unlike a facial vein, this has almost a straight course. Usually it begins as the angular vein from the angle between the nose and the eye, and then courses the facial artery at the level of inferior border of mandible, but it lies mostly posterior to the artery. Unlike the facial artery, this runs laterally to the submandibular gland and then drains into the IJV. Right? And anatomy related to the retromandibular approach. What are the things you will face here is your retromandibular vein and a different part of your facial nerve. Retromandibular vein again is formed by the superficial temporal vein and the maxillary vein. It descends posterior to the ramus into the substance of parotid. So, and facial nerve. I'm not going to talk on the superior part because that is dealt with somebody else. It usually external artery meatus, it comes below 2.3 centimeters or 2.5 centimeters. I am not a believer of this millimeters and centimeters because different sizes of faces are there. So approximately 2.5 centimeters below the EA external artery meatus. And then posterior to the parotid gland, and it is 2 centimeters or 3 centimeters deep to the parotid gland. That is where you have to identify this facial nerve. Mostly marginal mandibular nerve descends down and forward the lower third of the ramus. So it has a space in between the branches. So that is where we have to maneuver to prevent injuries. That is where we have to identify and then maneuver to the mandible. Right. Again, retromandibular vein. This is the posterior facial vein. It's formed from the upper portion of the parotid gland and deep to the neck of the mandible. So, descending towards posterior border of the ramus of the mandible through the parotid gland, it's folded in this deep aspect. Usually, it is lateral to the external carotid artery. So, you don't get to see the ECA, but you will end up seeing the retromandibular vein if you go deep into the parotid gland. So, if you stay away in the anterior border, most of the time, retromandibular approach, you don't even see this retromandibular vein, but you have to be cautious when you are maneuvering on the retromandibular axis towards the ramus. And both the vessels are crossed by the facial nerve. So, and the apex of the parotid gland, the retromandibular vein gives off anterior branch also. It gives a descending communication that joins with the facial vein below the angle of the mandible. So, if you encounter, you have to ligate all these things. And it unites in the posterior auricular vein to form the EJV. So that is the relationship of your facial nerve and the vein. So that is the facial nerve, this is the mandibular branch, and this is the vein. So everything will be intertwined. Nerve will always be overlying the vein. So these are the commonest approach where we encounter into the mandible: submental, submandibular, retromandibular, preauricular and postauricular. Someone else is going to decide. So there are variations about these incisions, and I'll tell you about how to go about these things. These are the structures, various structures you are going to cut through. You know the anatomy, where it is, but what are the layers you are going to cut? Mainly, the submental incision, you have to cut through the skin, subcutaneous tissue, lattice-ma, and the mesenteric fascia. But your marginal mandibular nerve and all these facial vessels, most often, right, it lies deep to the lattice-ma. Till lattice-ma you don't encounter this. Of course, there are some anatomical variations. Sometimes the marginal mandibular nerve might be above the lattice-ma, but most of the time it is below the lattice-ma in the superficial layer of the cervical fascia, deep cervical fascia. And again, retromandibular, you have a different thing. You have a skin, subcutaneous tissue, and a mass layer in between, and a parotid fascia. When you are in submandibular, you don't get to this, but when you are lying on the paraangular incision or the retromandibular incision, you have a mass and a parotid fascia in between, and the parotid itself before encountering into the masseter. So that is the difference. And upper part, again, somebody else will deal. Right. Submental incision, most often I think you see a lot of lesions where you can mostly you can use for IND, and you can use for intubation, and some of the tumors mostly on the lingual side of the mandible. So mostly it is a parallel incision, or it corresponds to the curvature of the lower part of the mandible. And again, dissection is going to the subcutaneous skin, subcutaneous tissue, and lattice-ma. Once you are into the muscle, always use a blunt dissection, and then till you reach the periosteum. So that is the incision. That is one of the tumor where you can use, and you can extend the submandibular incision depending on the extent of the lesion. And another submandibular incision, it is made as mostly 2 to 3 centimeters below or 2 finger breadth. Always ask the inviver, right? They say it's 1 finger breadth or something like that. Whose finger, right? So if it is a bulky surgeon, so it's going to be different. Always, most often the answer should be the patient's finger, right? So that is the landmark. So if you avoid 2 centimeters below, you will avoid marginal mandibular nerve injury. If you are 4 centimeters away, you will avoid injury sometimes to the cervical branch as well. So the incision goes through the superficial layer towards the deep cervical fascia, where you get the facial artery vein in the marginal mandibular nerve, and then pterygomesenteric sling and periosteum inside at the lower border. So this is the incision through the skin, subcutaneous tissue to the level of the lattice-ma muscle. Lattice-ma muscle, again, once you reach the lattice-ma, you can see the fibers. Once you are deep down the subcutaneous tissue, you can see the direction of the fibers, which is almost vertical. That is where your lattice-ma lies. Always while making an incision, don't tunnel it, right? You have to undermine the incisions so that you will get a good exposure with the retractors. Always it should be like a V, inverted V, rather than like this conical shape. Then you will go narrow, narrow and narrow, you won't end up, you will struggle. So always undermine the lattice-ma muscle over the fascia completely, and then do a dissection. So once you cut the lattice-ma, it just retract and then give way. Your fascia will be right open. Then you can again dissect and then cut the fascia. Always, once you done with the lattice-ma, you can see the bulge of the submandibular gland. When you are going to cut through the deep cervical fascia, always the direction should be towards the mandible. That is the main thing. Otherwise, you will enter into the submandibular gland space or into the neck. So always go towards the mandible, oblique directions once you are below the lantissima when you are maneuvering through the deep cervical fascia. So always, sometimes you use a hemostat, beginners use a hemostat, do a blunt dissection. You can use a cautery or a scissors, just snip it. Don't cut like a tailor, just snip on the tip and then work towards the structures. Once you reach the facial vein and artery, usually comes in this region. They are supposed to be ligated at this level in the deep cervical fascia, and usually you have a lymph node which is caressing that. What is that lymph node called? Node of stars. That is a lymph node most commonly it is encountered. The facial artery will be in front, vein will be behind, and your nerve which will be superior to these structures most often. So you have to identify, and once if you identify a nerve, you dissect carefully, and so that it can be retracted easily. So you dissect the nerve for a few centimeters, 1 or 2 centimeters, and then it can be retracted easily. That is how you have to identify. Then you clamp these vessels. Right. So this is the relationship of the facial artery to the vein to the lymph node. That is, artery is anterior, vein is posterior, and see the nerve which is over the artery and facial. Just after getting into the lantissima vessel, you have to identify these things. Right. You can use an electric nerve stimulator if you have to identify the nerve in this regions. So it will be better off avoiding injury to the nerve, because in the beginning stage you don't know what is a muscle fiber, what is a nerve. So it's quite difficult, it will be very thin. So you can use a nerve stimulator if you have to. Once you are in the pterygomasseteric sling, again the incisions is made through the in the pterygomasseteric sling and not on the masseter, because when you are dissecting on the masseter, it may end up in bleeding, because this is the avascular plane. Almost bleeding will be less if you are going to incise in the pterygomasseteric sling. And then you use a periosteal elevator, completely elevate, so that there will be less hemorrhage, bothersome hemorrhage. So yeah, that is the incision. Yeah. I had lost some few minutes. I just go through. Yeah, that is the exposure. Once you incise the sling, once you are on the masseter, then you are safe, right? There is no structure, no nerve, no blood vessels. You incise and then down to the periosteum. Once down to the periosteum, you just retract as much as possible, whatever you want. So again, closure will be, you have to do a pterygomasseteric sling closure and then the subcutaneous tissue as well. So again, retromandibular approach, it's almost vertical to the posterior. There are modifications which will come later. If you want to do a retromandibular transparotid, it's almost vertical. If you want to do a retroparotid, it will be a bit oblique from the mastoid towards the angle of the mandible. So that is where, and you, as I said, skin, subcutaneous tissue, smash, and the parotid capsule. These are the areas we have to maneuver. Once you are into the parotid gland, you will encounter the nerve, right, facial nerve, and you have to maneuver in the direction of the nerve. All your dissection should be directed parallel to the nerve so that you won't cut it vertically. So maneuver through these branches. So that is the incision. And once you are blunt dissection, always use a blunt dissection in the parotid gland. Don't go deep beyond, so that you will encounter a retromandibular vein. If you identify, you have to ligate that. Otherwise, you have to retract that. Again, as I said, when you identify a nerve, dissect it nicely for 2 centimeters or something like that, so that you can retract it superiorly, and then go in between. Usually use a hemostat, which is repeatedly inserted and spread open along the direction of the nerve, that is parallel to the lower border of the mandible.
Arun, we'll take this in the TMJ.
Yeah, okay. Yeah, done. So this is a nerve stimulator. This can be used if you want. Just have a picture. And that is a sharp dissection to the lantissima muscle, smash parotid capsule, and then the blunt dissection to the parotid gland, and then the fibers, and then the exposure. I think she has a video on all these things. So that is the closure. So that's it for now, right? And I hope this is the future. A top crew is in action. Probably we'll have a lens to see all through these things and then maneuver. And I happen to be a roommate of Yash yesterday night. He showed me a robotic surgery video. Probably it's just in the new corner of it. Thank you.
Thank you so much.